Emergency department admissions follow strict protocols. Paramedic reports, triage assessments, physician evaluations. Every patient's arrival is documented from the moment they enter our facility. During my 7 years as an ER nurse at County General Hospital, I had processed thousands of admissions and understood the complex choreography that turns medical emergencies into organized patient care. But sometimes patients arrive through channels that don't appear in any protocol manual. Discovered her during my 2 a.m. rounds on a quiet Tuesday night. Bay 7 contained a stretcher I didn't remember seeing during my previous assessment, occupied by a young woman who wasn't listed on our census board. She appeared to be in her early 20s, with dark hair and pale skin, lying motionless under clean white sheets. No identification wristband, no personal belongings, no medical equipment connected to her care. She breathed quietly and steadily, but showed no response to my presence. "Excuse me," I said softly, approaching the stretcher. "Can you tell me your name?" No response. Her eyes remained closed, and she gave no indication of hearing my voice. I checked the area around Bay 7 for admission paperwork or paramedic reports. Nothing. No charts, no triage notes, no documentation of her arrival or medical condition. "Tom," I called to our charge nurse. "Do we have a patient in Bay 7? He consulted his clipboard and shook his head. "Bay 7 should be empty. We've only got 4 active patients tonight." But the young woman was clearly present, occupying a stretcher in a bay that should have been vacant. Tom followed me to Bay 7 and stared at the unexpected patient. How did she get here? Did paramedics bring her in? I don't know. She was just here when I made my rounds. We checked with the registration desk, but they had no record of any recent admissions. The security guard at the main entrance confirmed that no ambulances had arrived during his shift. "Maybe she walked in," Tom suggested, but the young woman showed no signs of being able to walk. She lay completely motionless, unresponsive to voice or touch, displaying the stillness of someone in a deep coma or heavily sedated state. Dr. Martinez, our night physician, arrived to assess the mysterious patient. He performed a thorough examination, checking vital signs, reflexes, and responsiveness. But his evaluation raised more questions than answers. "Her vital signs are stable but unusual," he reported. "Heart rate exactly 60, blood pressure precisely 120/80, temperature exactly 98.6 degrees. Perfect textbook vitals, but almost too perfect." "What do you mean?" "Normal vital signs fluctuate slightly. Heart rate varies by a few beats per minute. Blood pressure shifts with breathing. Temperature changes throughout the day. But her readings are mathematically perfect, as if they've been set rather than measured." Dr. Martinez attempted to wake the patient using standard neurological assessment techniques. Verbal commands, physical stimulation, light pressure on nerve points. But she remained completely unresponsive. "We need to admit her for observation," he decided. Unknown patient. Unknown medical history. Unknown reason for unconsciousness. I'll write orders for basic monitoring and supportive care. But when Dr. Martinez tried to create a medical record, the computer system wouldn't accept the admission. Without identification or insurance information, the patient couldn't be officially registered. "We'll have to treat her as a Jane Doe," he said. "Social services can work on identification in the morning." I prepared Bay 7 for extended patient care, connecting cardiac monitoring equipment and establishing IV access for hydration. The young woman tolerated all procedures without reaction, maintaining her perfect vital signs throughout the interventions. But when I tried to document my nursing care, I discovered that someone had already begun charting for the mysterious patient. A medical record existed under the name Jane Doe, with detailed nursing notes describing her condition and care requirements. The documentation was written in professional medical shorthand, properly formatted and signed, but none of the nurses on duty had written those notes. The handwriting wasn't mine, wasn't Tom's, and didn't match the documentation style of any ER staff member I recognized. But the notes were accurate, describing the patient's condition and the care she had received with clinical precision. 300 hours. Patient found unresponsive in Bay 7. Vital signs stable. No identification or medical history available. Appears comfortable, no signs of distress. Monsieur Thompson, RN. There was no M. Thompson on our nursing staff. Additional entries appeared throughout the night, documenting routine assessments and care activities. $100 hours. Vital signs unchanged. Patient remains unresponsive but stable. Repositioned for comfort. No family or visitors present. Monsieur Thompson, RN. 300 hours. IV fluids running as ordered. No change in neurological status. Skin warm and dry. Continues to breathe spontaneously. Monsieur Thompson, RN. Each entry was medically appropriate and professionally written, describing care that was actually being provided to the mysterious patient. But Monsieur Thompson didn't exist. I compared the handwriting to nursing documentation from previous shifts, searching for any match among current or former staff members. The script was neat and professional, clearly written by someone with medical training, but it didn't correspond to any nurse in our employment records. By morning, the Jane Doe chart contained 8 hours of detailed nursing notes, all signed by the phantom M. Thompson. The documentation was thorough and accurate, describing a night of appropriate medical care provided by a nurse who wasn't scheduled to work. During the 7 a.m. shift change, I briefed the day nurse about our mysterious patient and the impossible documentation. But when she went to check on Jane Doe, Bay 7 was empty. No stretcher, no patient, no medical equipment. The bay looked as if it had been cleaned and prepared for the next admission, with no evidence that anyone had occupied the space overnight. "Where's the Jane Doe patient?" she asked. "She was right here. Unconscious young woman, no identification. We searched the entire emergency department, thinking the patient might have been moved to another bay or transferred to an inpatient unit. But no one had any record of the mysterious woman. The registration system showed no Jane Doe admission. The security cameras had no footage of anyone entering or leaving Bay 7. The stretcher that had held the patient was nowhere to be found, but the medical chart remained. 8 hours of nursing documentation, signed by Monsieur Thompson, describing care provided to a patient who had apparently vanished along with all physical evidence of her presence. Administration investigated the incident as a potential security breach, but they found no explanation for how a patient could appear and disappear without leaving any trace except impossible medical records. The nursing notes are professionally written, the quality assurance manager reported. They describe appropriate care for an unconscious patient, but we have no Monsieur Thompson on staff and no record of the patient these notes describe. The chart was filed as an administrative anomaly, but it remained in our medical record system as evidence of care provided to someone who may never have existed. I've thought often about the young woman in Bay 7 and the mysterious nurse who documented her care. Perhaps some patients exist in the spaces between official admission and discharge, receiving treatment from staff members who work shifts that don't appear on any schedule. And perhaps the most important medical care is sometimes provided by people whose names don't appear in employment records, whose documentation serves as the only proof that certain patients received the attention they needed during their brief stays in our emergency department. Some admissions, I've learned, occur outside normal protocols, and some nursing care is provided by colleagues whose existence can only be verified through the professional quality of their medical documentation. The chart remains in our files, signed by Monsieur Thompson, describing excellent care provided to a patient who disappeared as mysteriously as she had arrived, leaving behind only the evidence that someone had been watching over her during the night when no one else could explain how she had come to be in our care. Hospital mirrors serve practical purposes: patient grooming, medication preparation, clinical assessments. The reflected surfaces in patient rooms support both medical care and personal dignity. In my 11 years as a night nurse in the progressive care unit at General Hospital, I had used countless mirrors for routine patient care without ever questioning their reliability. But the mirror in Room 9's bathroom began showing reflections that didn't match reality. Mrs. Elena Rodriguez was our patient in Room 9, recovering from complications following cardiac surgery. She was a pleasant woman in her 60s, alert and cooperative despite her serious medical condition. Her recovery was progressing normally when she began making unusual comments about the bathroom mirror. That mirror shows terrible things, she told me during my evening assessment. You should have it removed. What kind of terrible things, Mrs. Rodriguez? It shows people dying, people who are going to die. She shuddered and looked away from the bathroom doorway. I don't want to see those images. I assumed she was experiencing anxiety or possible medication side effects that were causing disturbing hallucinations. Cardiac patients often struggle with fear and depression during recovery, and visual distortions aren't uncommon. The mirror is just reflecting the normal bathroom, Mrs. Rodriguez. Sometimes when we're not feeling well, our minds can play tricks on us. But she remained adamant. Please don't look in that mirror. It will show you things you don't want to see. Later that evening, I used the bathroom mirror in room 9 to check my appearance after a particularly busy period of patient care. The reflection looked normal. Tired nurse at the end of a long shift, hair slightly disheveled, uniform wrinkled from hours of patient lifting and repositioning. But something was wrong with my reflection's eyes. They looked older, more lined, marked by an exhaustion that went deeper than ordinary fatigue. The face in the mirror showed signs of aging that didn't match my actual appearance. I looked away, assuming the unflattering lighting was creating harsh shadows. When I looked again, my reflection appeared normal, but Mrs. Rodriguez watched me emerge from the bathroom with concern. You saw it, didn't you? The mirror showed you something. Just tired lighting, I replied, but I felt unsettled by the experience. Over the following nights, other staff members began reporting unusual experiences with the mirror in room 9. Reflections that didn't quite match their actual appearance, images that suggested injury or illness, not present in reality. I looked ancient in that mirror, complained Janet, one of our senior nurses. Like I'd aged 20 years. My face was all wrinkled, my hair was gray. But I felt fine. Dr. Peterson mentioned seeing scratches on his face in the mirror that weren't actually there. Looked like I'd been in a fight, but when I touched my face, my skin was normal. But the most disturbing reports came from Mrs. Rodriguez herself. She claimed the mirror was showing her staff members who wouldn't survive their shifts. Nurse Williams looked terrible in the mirror, she told me one morning. Pale, sick, like she was dying. Please check on her. I found Nurse Williams at the medication station, looking perfectly healthy and alert. But when I mentioned Mrs. Rodriguez's concern, Williams became thoughtful. That's strange. I've been feeling off all morning. Not sick exactly, but different. Like something's not right. Williams left work early that day, complaining of sudden onset fatigue and chest pain. She was admitted to our emergency department and diagnosed with a heart attack that could have been fatal if not treated immediately. The mirror had somehow predicted Williams's cardiac event hours before symptoms became apparent. Mrs. Rodriguez continued to provide warnings based on what she saw in the bathroom mirror. Dr. Martinez looks very pale in the reflection. His hands are shaking. Martinez was diagnosed with severe anemia the following day. The housekeeping lady appears to be limping badly. Maria from housekeeping fell on ice that evening and broke her ankle. Each prediction proved accurate, as if the mirror was showing future medical conditions that hadn't yet manifested in the people it reflected. But the most unsettling aspect was when the mirror showed no reflection at all. I can't see you in the mirror anymore, Mrs. Rodriguez told me during my Thursday night assessment. When you go into the bathroom, there's no reflection, just empty space where you should be. I tested this myself, standing directly in front of the bathroom mirror in room 9. Mrs. Rodriguez was correct. No reflection appeared. The mirror showed the bathroom clearly, but my image was completely absent from the reflected scene. What does it mean when someone has no reflection? I asked Mrs. Rodriguez. She looked frightened. It means they won't be here much longer. The mirror stops showing people who aren't going to make it. But I felt fine. No symptoms, no health concerns, no indication of impending medical problems. The absence of my reflection seemed like a malfunction of the mirror rather than a prediction of my demise. However, 3 other staff members reported similar experiences that week. No reflections in the mirror, despite feeling healthy and showing no signs of illness. By Friday morning, all 3 had called in sick with severe flu symptoms that developed rapidly into pneumonia, requiring hospitalization. I began avoiding the mirror in room 9, but Mrs. Rodriguez continued to monitor its predictions and warn staff members about what she observed in their reflections. "The new doctor looks very bad in the mirror. Tell him to be careful. That respiratory therapist has no reflection anymore. She should go home. The chaplain's reflection shows him falling. Watch out for him on the stairs." Each warning proved prophetic. The new doctor developed appendicitis. The respiratory therapist was diagnosed with COVID-19. The chaplain fell downstairs and broke his leg. Administration decided to remove the mirror from room 9, thinking it was causing psychological distress for Mrs. Rodriguez and contributing to staff anxiety about health predictions. But the night before the mirror was scheduled for removal, Mrs. Rodriguez made one final observation. "I can see myself clearly now," she said peacefully. "Very clearly. I look ready." Mrs. Rodriguez died quietly in her sleep that night, her heart simply stopping during the early morning hours. A peaceful death, consistent with her cardiac condition, but unexpected given her apparent improvement over the previous days. The mirror was removed as planned, replaced with a standard bathroom mirror that showed normal reflections without predictive capabilities. But Mrs. Rodriguez's predictions continued to prove accurate even after her death. The staff members she had warned about maintained heightened awareness of their health, often discovering medical issues that might have been overlooked without her supernatural early warning system. I've come to think of the mirror in room 9 as a diagnostic tool that operated outside normal medical parameters, providing advance notice of health problems through reflections that transcended present reality. Mrs. Rodriguez served as an interpreter for the mirror's predictions, translating visual warnings into actionable medical advice that saved several lives during her stay with us. Some diagnostic equipment, I've learned, doesn't appear in medical supply catalogs, and some patients provide services that extend beyond their own medical needs, serving as conduits for information that helps protect the staff who care for them. The mirror may be gone, but its warnings continue to influence how I approach my own health and the health of my colleagues, maintaining awareness that some problems can be detected before they become apparent through conventional means, even when that detection comes from bathroom mirrors that show futures we're not prepared to face. Interpreted by patients who understand that reflection and reality don't always correspond in the ways we expect. Hospital payroll systems maintain precise records of nursing hours, clock-in times, break schedules, overtime calculations. Every minute of patient care is documented for both financial and regulatory purposes. After 15 years of nursing, at Metropolitan Medical Center, I had never found errors in my timesheet until I began working shifts I didn't remember. The first discrepancy appeared on my November paycheck. An extra 12-hour overnight shift, Monday through Tuesday, that I had no memory of working. According to the payroll system, I had clocked in at 7 p.m. and worked until 7 a.m., caring for patients in the intensive care unit. But I had been home that night, sleeping in my own bed after completing my regular Sunday day shift. I remembered the evening clearly, dinner with my husband, watching television, going to bed early. I definitely hadn't worked an overnight shift. There must be some mistake, I told Sharon, our payroll administrator. I wasn't scheduled for Monday night. I was home. Sharon checked her computer system thoroughly. According to our records, you clocked in at 19 widow's hours and worked a full 12-hour shift. Your badge was scanned for breaks at the appropriate times, and you clocked out at 07 hours Tuesday morning. But I didn't work that shift. Someone else must have used my badge. The time clock system uses biometric verification, Patricia, fingerprint scan and badge code. Only you can clock in with your credentials. But I was certain I hadn't worked. Monday night, my husband confirmed I had been home, sleeping peacefully beside him throughout the night. Sharon expanded her investigation, checking with the ICU charge nurse who had supposedly supervised my phantom shift. Linda Martinez confirmed that I had worked Monday night, caring for 3 critical patients with professional competence. You did excellent work, Linda told me. Mr. Johnson was having breathing difficulties and you managed his ventilator settings perfectly. Mrs. Chen needed frequent repositioning, and you kept her comfortable throughout the night. You even helped Dr. Williams with the emergency intubation in room 314, but I had no memory of any of these patient interactions. I didn't recall caring for Mr. Johnson, Mrs. Chen, or assisting with an emergency intubation. Are you feeling all right? Patricia? Linda asked. Sometimes stress can affect memory, especially with night shift work. But I felt fine, and I was certain about my whereabouts Monday night. I had been home, not working in the ICU. The situation became more disturbing when I reviewed the nursing documentation for that shift. My handwriting appeared throughout the patient charts, recording vital signs, medication administration, and clinical assessments for 3 critically ill patients. 2100 hours, Mr. Johnson's oxygen saturation 94%, increased PEEP to 8 cm H2O. Patient tolerating ventilator changes well. P. Stevens, RN. 2300 hours, Mrs. Chen repositioned to left side. Skin assessment shows no pressure points. Family visited, provided emotional support. P. Stevens, RN. 0130 hours. Assisted Dr. Williams with emergency intubation. Room 314. Patient stabilized, sedated for comfort. P. Stevens, RN. My signature, my documentation style, my clinical observations. But I had no memory of providing this care or writing these notes. I brought photocopies of the documentation to show my husband. Do you recognize this handwriting? He examined the nursing notes carefully. That's definitely your writing, honey. Same style you use for grocery lists and birthday cards. But you said you were home Monday night. I was home. I remember going to bed at 10 p.m. and sleeping until 6 a.m. Then who wrote these notes? I had no answer for that question. The pattern continued over the following weeks. Additional overnight shifts appeared on my timesheet, always on nights when I remembered being home. Each phantom shift included complete documentation in my handwriting, describing patient care I had no memory of providing. But the patients I had supposedly cared for were real, and their outcomes were excellent. Mr. Johnson recovered from his respiratory crisis. Mrs. Chen's comfort care helped her pass away peacefully. The emergency intubation I had allegedly assisted with saved a patient's life. Whoever was working these shifts using my identity was providing outstanding nursing care. Patricia, Linda approached me during one of my scheduled day shifts. I wanted to compliment you on your night work. The family of Mrs. Patterson specifically asked me to thank you for the compassionate care you provided during her final hours. Mrs. Patterson? Tuesday night. You stayed with her when she was dying, held her hand, made sure she wasn't alone. The family was so grateful. But Tuesday night I had been home, helping my daughter with her college applications. We had worked until nearly midnight, and my husband had made popcorn while we filled out financial aid forms. I was definitely not in the hospital holding Mrs. Patterson's hand. Yet the nursing notes showed detailed documentation of end-of-life care provided to Mrs. Patterson by P. Stevens, RN. My signature appeared on hourly assessments, comfort care interventions, and family communication logs. She passed very peacefully, Linda continued. You did beautiful work with her family. That's the kind of nursing that makes a real difference. I wanted to explain that I hadn't been there, but how could I argue with documentation in my own handwriting describing care that everyone remembered me providing? The phantom shifts began affecting my scheduled work. Other nurses would mention conversations we had supposedly had during overnight hours when I was home sleeping. Thanks for covering for me during that code blue Friday night, said Jennifer, one of the ICU nurses. I really needed the bathroom break. I wasn't here Friday night. Jennifer looked confused. You were right there beside me. We worked on Mr. Davis together for 40 minutes. But Friday night I had attended my book club meeting, then gone home and read until 1 a.m. 6 people could verify my whereabouts during the time I was allegedly assisting with cardiac resuscitation. I began keeping a detailed log of my actual activities during the nights when my phantom self was apparently working. Movie receipts, restaurant bills, photographs with timestamps. Evidence that I was elsewhere when my doppelganger was providing patient care. But the evidence seemed meaningless compared to the consistent testimony of colleagues who interacted with my other self during those overnight shifts. "Patricia, you seem tired lately," Dr. Williams mentioned during one of my day shifts. "Are you getting enough rest between your day and night work?" "I only work day shifts, Dr. Williams." He looked puzzled. "But I see you here several nights a week. We've had multiple consultations about patient care during overnight hours." According to Dr. Williams, my night shift self was an excellent nurse who provided thoughtful patient care and valuable clinical insights. But that version of me was apparently working without my knowledge or memory. Administration investigated the situation as a potential payroll fraud, but they found no evidence of wrongdoing. My fingerprints authenticated every clock-in. My documentation was professionally appropriate, and patient outcomes under my care were consistently positive. "We can't find any policy violations," the nursing supervisor reported. "Your work is exemplary, whether you remember it or not." But I was concerned about the psychological implications of working shifts I couldn't remember. Was I experiencing some form of dissociative disorder? Was the stress of nursing causing memory problems? I consulted a physician about possible causes of memory loss. But my physical and neurological examinations were normal. I was healthy, alert, and showed no signs of cognitive impairment. The phantom shifts continued for 6 months, appearing on my pay stubs and in patient charts throughout the winter. My night shift self apparently specialized in end-of-life care, consistently being assigned to patients who were dying and their families who needed emotional support. Families began requesting me specifically for overnight shifts during difficult times, praising the compassionate care my other self provided during their darkest hours. "She was an angel," one daughter told me after her mother's death. "You sat with us all night, explained everything that was happening, helped us say goodbye. We'll never forget your kindness," but I remembered none of it. In spring, the phantom shifts stopped appearing on my timesheet. My documented hours returned to normal, matching the shifts I actually remembered working. But patient charts throughout the hospital contained months of nursing notes in my handwriting, describing care I had provided to people I had never consciously met. I've come to think of my night shift self as a version of my professional identity that emerged to meet needs I couldn't address during regular working hours. Perhaps some patients require care that can only be provided by nurses who exist in the spaces between memory and duty, working shifts that exist outside normal scheduling systems. The documentation remains in patient files throughout the hospital, signed with my name describing excellent nursing care provided during hours when I was home sleeping, evidence that some forms of professional dedication transcend conscious awareness, creating versions of ourselves that work when our physical bodies are resting. And perhaps that's not entirely troubling. If patients received compassionate care during their most vulnerable moments, if families found comfort during difficult nights, if lives were saved through nursing interventions I don't remember providing, then maybe the mechanism matters less than the outcome. Some service, I've learned, occurs beyond the boundaries of what we can consciously remember or control. And some of the most important nursing care might be provided by versions of ourselves that exist only in the documentation systems that prove we were present when we were needed most. Shift change represents the most critical communication in hospital nursing. Every patient's condition, every medication schedule, every concern must be transferred from departing staff to incoming caregivers with absolute precision. In my 18 years as night supervisor at Sacred Heart Hospital's medical unit, I had conducted thousands of shift reports, ensuring continuity of care through the sacred ritual of professional handoff. But the morning I discovered we were caring for 13 patients in a 12-bed unit changed everything I understood about patient accountability. The night had been routine. Census at capacity with 12 patients distributed across our standard bed assignments, each receiving appropriate care for their respective conditions. Cardiac monitoring for Mr. Thompson in bed 1, diabetic management for Mrs. Garcia in bed 7, post-surgical observation for Mr. Chen in bed 12, standard patient load, familiar diagnoses, nothing unusual about the shift's activities. But when I began preparing the morning report at 6:45 a.m., My documentation showed 13 patients. The additional entry appeared between beds 6 and 7. Bed 6A, Williams Eleanor, age 82. Diagnosis, chronic heart failure. Condition stable overnight. Vital signs within normal parameters. Family notified of continued improvement. I stared at the handwritten entry, confused by the impossible bed number. Our unit contained 12 beds, numbered 1 through 12 in standard sequence. There was no bed 6A, no space between beds 6 and 7 for an additional patient. But my documentation clearly showed care provided to Eleanor Williams throughout the night. Vital signs recorded every 2 hours, medication administration logged appropriately, clinical assessments noting stable cardiovascular status, all written in my own handwriting. I walked through the unit, counting beds to verify the physical layout. 12 patient rooms, 12 beds, 12 occupied spaces. But according to my nursing notes, I had cared for 13 people during the night shift. Martha, I called to one of our senior nurses. Do we have a patient named Eleanor Williams? She consulted her assignment sheet. Not on my list. What room? My notes say bed 6A. Martha looked puzzled. There is no bed 6A. We only have 12 beds. But I had detailed documentation showing 8 hours of nursing care provided to Eleanor Williams in the non-existent bed 6A. Medication administration times, vital sign assessments, family communication logs, all properly recorded according to hospital protocols. The morning nurse, David Rodriguez, arrived at 7 a.m. for shift report. He was a reliable colleague with 12 years of experience, someone who knew our unit's layout and patient capacity as well as anyone. Ready for report? He asked, settling in with his notebook. I began the standard handoff ritual, presenting each patient's condition and care requirements. Beds 1 through 6 proceeded normally, with David asking appropriate questions and making relevant notes. Bed 6A, I continued, reading from my documentation. Eleanor Williams, 82 years old, chronic heart failure, stable overnight, good response to diuretic therapy. Family visited at 2 a.m., daughter concerned about discharge planning. David nodded and made notes in his report sheet. Any changes in her medication regimen? Dr. Peterson increased her Lasix to 40 milligrams twice daily. She's responding well. Output has improved. I'll make sure to monitor her fluid balance closely. We continued through the remaining patients, beds 7 through 12, completing the handoff process normally. But when I reviewed my notes, I realized David had accepted information about Eleanor Williams without questioning the impossible bed assignment. David, I said as we finished the report, did you notice anything unusual about bed 6A? He looked at his notes. Eleanor Williams? She seems stable. Why? There is no bed 6A. We only have 12 beds in this unit. David smiled with the expression I had never seen before, knowing, peaceful, almost secretive. We always carry one more, he said simply. What do you mean? Every unit carries one more patient than the official census. Someone who needs care but doesn't fit into normal admission categories. I stared at him, trying to understand what he was suggesting. David, that doesn't make sense. We can't care for patients who don't have beds. Eleanor Williams has been in bed 6A for 3 months, he replied calmly. She's one of our most stable patients. Never complains, never requires urgent intervention, just needs consistent monitoring and medication management. But there is no bed 6A. David checked his watch. I should start my rounds. Thanks for the excellent report. He walked away, leaving me confused and unsettled by his casual acceptance of an impossible patient assignment. I spent the morning investigating Eleanor Williams' status in the hospital computer system. No admission record, no insurance information, no physician orders, no official documentation of her existence. But my handwritten nursing notes showed 3 months of continuous care provided to Eleanor Williams in bed 6A. Detailed assessments, medication administration, family communications, clinical observations, all documenting treatment for a patient who apparently didn't exist in hospital records. I approached other night shift nurses about Eleanor Williams, but their responses were evasive and unsatisfying. Oh, Eleanor, sweet lady, always grateful for help. She's doing much better since her last medication adjustment. Her daughter visits regularly. Very devoted family. Everyone seemed familiar with Eleanor Williams, but no one could explain where bed 6A was located or how we were providing care to a patient who didn't appear in official records. Dr. Peterson, mentioned in my notes as Eleanor's attending physician, acknowledged her existence when I asked about medication changes. Eleanor's responding well to the increased diuretic dose, he confirmed. Her heart failure symptoms have improved significantly. Dr. Peterson, where exactly is Eleanor Williams located? He looked surprised by the question. Bed 6A, of course, where she's been since September. But when I pressed him to show me bed 6A, Dr. Peterson became distracted and excused himself to attend to other patients. Over the following weeks, I continued to document care for Eleanor Williams during every night shift. Her condition remained stable, her family stayed involved in her care, and her treatment progressed normally. But I never saw her. I never entered bed 6A, never spoke with Eleanor Williams, never provided the hands-on patient care that my documentation described in careful detail. Yet my nursing notes accumulated, creating a comprehensive medical record for someone I had never consciously encountered. The phenomenon extended beyond Eleanor Williams. Other nurses began mentioning additional patients who didn't appear on official census reports. The gentleman in 3B is asking for ice chips. Did someone check on the lady in 9A? She seemed uncomfortable earlier. Family is here to visit the patient in 11A. Bed numbers that shouldn't exist. Patients who required care but didn't occupy official hospital beds. I realized that our 12-bed unit was somehow accommodating 15 or 16 people, providing medical care to patients who existed in the spaces between official admissions and documented bed capacity. During one conversation with David Rodriguez, I asked directly about the unit's actual capacity. How many patients are we really caring for? He considered the question carefully. As many as need care. The official census helps with staffing and billing, but patient needs don't always conform to administrative categories. So we provide care to people who aren't officially admitted. We provide care to people who need it. Some of them happen to have official bed assignments. Some of them find other spaces where healing can occur. I began to understand that Sacred Heart's medical unit operated on multiple levels simultaneously. Official patients with documented admissions, insurance verification, and physician orders. And unofficial patients who somehow received the same quality of care through systems that existed outside normal hospital administration. Eleanor Williams represented the latter category, someone who needed medical attention and somehow attracted the nursing care required for recovery, even though she couldn't be officially admitted through conventional channels. Her steady improvement over the months suggested that unofficial patients responded to treatment as well as those with proper documentation. I've come to accept that some hospitals provide care that extends beyond their official bed capacity, accommodating patients who fall through administrative cracks but still deserve professional medical attention. The morning handoff ritual continues to include patients who exist in impossible bed assignments, their conditions reported with the same precision and care provided to officially recognized admissions, and perhaps that's appropriate. Healing doesn't require proper insurance verification or official bed assignments. Some patients need care that transcends administrative boundaries, finding spaces where medical attention can be provided regardless of documentation status. We always carry one more, as David explained, because compassion doesn't observe the limits of official capacity, and some patients receive treatment in the unmapped spaces where human need intersects with professional dedication. The 13th patient in our 12-bed unit reminds us that the most important aspects of nursing care occur in the spaces between what we can officially document and what we know is necessary for healing.